Welcome back to the Pelvic Health Summit. I'm here with Dr. Kerin Orbuch. She is a board-certified OBGYN and the director of the Advanced Gynecologic Laparoscopy Center in both New York and Los Angeles. She specializes in pelvic pain and endometriosis, and she has a bicoastal practice. Thank you so much for being here.
Thank you for having me.
So tell us a little bit about your practice and approach.
Sure. So I'm fellowship trained in minimally invasive surgery with a focus on endometriosis treatment. And the surgical treatment for endometriosis is excision of endometriosis. That means in a minimally invasive fashion or laparoscopic or robotically excising or removing the endometriosis. But what I've learned is that endometriosis affects so much more, meaning typically when a woman has endometriosis, we need to address her from the mind down to her toes. And most women with endometriosis have multiple other reasons for having pelvic pain, many of whom have pelvic floor dysfunction, meaning tight muscles. Many have interstitial cystitis. Many have an upregulated central nervous system known as central sensitization. So it's my job when a woman comes into my office to listen to them, to listen to all of their symptoms, all of their complaints, to try and identify the multiple reasons why they have pain, and then to create a treatment plan addressing each one of their coexisting conditions. Typically, the mainstay of what I do is surgical excision of endometriosis, excision being the particular type of surgery that's required when a woman has endometriosis. But I do so much more, and I don't jump to surgery. That's part of the treatment plan, but it's addressing the mind down to the toes, typically from an east meets west approach is how I address my patients.
Fabulous. I love that east meets west approach. Can you tell us a little bit more about that in detail, how you incorporate mind and body in your practice?
Sure. Well, when a woman comes into my office, the first thing I actually do is I listen to them. And I can learn a lot by the way she's describing her pain. Can she sit in the chair for the hour and a half that we're talking? Does it hurt for her to sit in the chair? Does she need to keep getting up in order to alleviate pain from sitting? Is she getting up to urinate multiple times during our lengthy consultation? Does she describe external influences in her life that perhaps worsen her pain, maybe a high pressure job or a difficult social life? And I typically always start with nutrition. And I'm a big proponent, I'm a health junkie myself, but I'm a big proponent of like an anti-inflammatory diet, organic foods, because pro-inflammatory foods tend to aggravate inflammatory conditions, endometriosis being an inflammatory condition. So I think eating right, I counsel women, and I go into much more depth about how you eat correctly. I think adopting a lifestyle where it allows you to begin your day, whether it's with mindfulness or meditation or doing yoga, whether it's going for a walk, whether it's cooking, whatever it is that relaxes and calms you, even if it's 10 minutes a day. I think it's very important when a woman has pain, and typically endometriosis is one of the reasons. I know in the summit, you're talking about a lot of different reasons why a woman and a man has pain, but all of those can upregulate a central nervous system. So the more that we can kind of quiet a central nervous system, the better we're going to be able to take care of one's pain. So I'm always, like I said, starting with diet, nutrition, incorporating a lifestyle that's healthy, incorporating exercise. It doesn't have to be crazy exercise. If someone likes to go for walks, that's fine. If someone is like a big into yoga, that's fine. Whatever, I try and modify based on an individual, what an individual likes. I think there's definitely a role for acupuncture, or massage, or just whatever one likes that can help relax them. So those are pretty basic steps that are without any risk or without any harm, meaning the benefit is outweighing any risk. And then there's a lot of, depending on what reasons why a woman has pain, then I will adopt and prescribe essentially other ideas or other approaches to help them with their pain. Now, it doesn't mean we don't use a Western approach. I will start with an Eastern approach and we'll combine it together with a Western approach.
Definitely. And one of the things I've been really learning from the summit, and now from you as well, is that it is so important to take care of yourself, not just the center of where it hurts, but yourself as a whole body and whole being. And definitely diet, and we've been interviewing a bunch of other more mind-body focused people. And so it's really nice to know that someone with your incredible bio and credentials is incorporating those things into your practice as well. So let's get into a little bit of the treatment side of things. Can you walk us through some of the different treatments that you offer and what an experience could be like coming into your practice for treatment?
Sure. So I assume we're talking about a woman with endometriosis. Now, but typically a woman comes into my office and is describing a whole host of symptoms that 100% of those symptoms actually may be because of endometriosis, or maybe only a quarter of the symptoms are due to endometriosis, and the other 3/4 could be due to other coexisting conditions. So I always ask for the medical records in advance, and I try and read women's imaging, ultrasounds, if they've had any CT scans, any emergency room visits, any prior operative reports, pathology reports, anything. I just try and read anything that is given to me, any lab work. And then when a woman walks into my office, I just tell them, I can imagine why you're here, but in your own words, where did this all start? Because it's important for me to know if they're 36 and they're saying, oh my gosh, since the first month I got my period when I was 12, I had debilitating pain and I went to the nurse's office, right? So that means if they're coming to me, let's say age 36, and they're starting at 12, it's over 20 years of symptoms, as opposed to a woman who's coming in at 36 and said, wow, I have been perfectly fine and for the last 2 years. So that's a whole different set of symptoms that a woman's having and a different timeline. So I really listen to a woman. I identify all the different reasons why they have symptoms. Typically, most women with endometriosis will present with intestinal symptoms initially, meaning they'll have constipation or bloating or diarrhea or painful bowel movements. And just from the straining on the toilet and the straining from the constipation, they'll have pelvic floor tight muscles. So typically the first stop, in addition to eating right and mindfulness, I'll send them to a pelvic floor physical therapist and to address their tight muscles, because the tight muscles in and of themselves can be upregulating a woman's central nervous system and causing a whole host of symptoms in addition to their endometriosis symptoms. So I have to listen, figure out what kind of symptoms they're having, where are they coming from, and then create a treatment plan based on those. But typically most women do have pelvic floor tight muscles. I'll send them for PT. And then if they have endometriosis and they need a good surgery, typically in an ideal setting, a woman has done a lot of research and they haven't had any surgery, which is fantastic. Unfortunately, most of the time, a woman has had 1, 2, 4, 5, 8, or 10 laparoscopies that perhaps were not done properly, where there was burning or laser or ablation or cautery. And the endometriosis implant was burnt rather than removed. And then that causes more scarring, more problems. So I really have to go back and explain and really lay the groundwork so a woman can build upon and understand, why is this surgery going to be different? And what did all of those surgical interventions do to their central nervous system? How did it upregulate their central nervous system? So we have to identify every reason a woman has pain and then create a treatment plan for every reason. And then typically, if they haven't not had a good surgery or they haven't had a proper surgery, an excision of endometriosis done in a minimally invasive fashion is typically something that I recommend, but I never start with that. I start with all those other things. I try and get them into PT for at least 6 or 8 or 10 sessions, or I try to get them into mindfulness. I try and get them to start eating right. I try and get them to change their lifestyle, because that will make a big difference once I give them a good surgery, then they continue down the path of a healthy lifestyle. Because each woman needs to identify, they're coming in with a whole host of symptoms, but if they think my surgery is going to fix their tight muscles, it's not going to. My surgery is going to fix the endometriosis that thereby cause perhaps the constipation and the straining on the toilet. But the tight muscles that are a result of the endometriosis need to be fixed by pelvic floor physical therapy. So I spend a lot of time educating and starting a patient with non-surgical options as we lead up to surgery. It's not instead of, it's in addition to enhance the surgical outcome.
Definitely. And for those who don't have the pleasure of working with you as their surgeon, what are some important questions to ask a surgeon who is about to perform a laparoscopy?
So you really want each woman to do a lot of research, because there's just a handful of endometriosis excision surgeons across the country. Because even in my residency, I was not trained to do endometriosis excision. I only learned that actually in my fellowship. And endometriosis also has a lot of different visual appearances at the time of laparoscopy. Honestly, none of which that I was taught during my 4 years of residency, all of which I was taught only in my advanced fellowship on minimally invasive surgery. So because endometriosis can have variable appearances, in residency I learned about powder burn lesions. That's what I knew. Chocolate cysts, those two appearances. But in actuality, endometriosis can appear as clear vesicles, particularly in adolescents and teens. It can be red, it can be white, it can be brown, it can be fibrotic, which is engulfed in a lot of scarring. It can be these peritoneal windows, meaning you have to be able to A, identify the endometriosis, and then B, be able to treat it properly, which is through excision of endometriosis. So what I would encourage women to ask their doctors is, one, do you do excision, okay, of endometriosis? And the woman has to then take the question a step further, because lots of doctors will say, yes, I do excision, when all they do is one excisional biopsy. So they're removing one lesion by excision. It's 1 millimeter or 2 just to have the pathological report say endometriosis, but the rest of the endometriosis they burn or laser or cauterize. So they have to really try and figure out the physician's aptitude for excision of endometriosis. If someone's doing 200 deliveries a year, there's no way that they can focus on endometriosis excision. I don't deliver babies. God bless a general OBGYN. Their breadth of knowledge is like this, right? So they know how to deal with menopausal health. They know how to do a C-section, a vaginal delivery. They know how to deal with nipple masses, breast masses, warts, abnormal pap smears, but their depth of knowledge can't be too deep because their breadth is so wide. I have a very narrow focus, so I can know a lot about one subject. God bless a generalist. So you really need to really ask the OBGYN, is this your specialty? How much do you do? What are you going to do if you find that the endometriosis is stuck to my bowel? Mm-hmm. Because often the endo is stuck to the bowel. You don't want a doctor to say, well, then I'll close you up and send you to someone else. You want that doctor to do, at the same surgical setting, A, diagnosis of endometriosis, and B, an excision of endometriosis. So you need it all in one. So you probably have to do a lot of searching to find that doctor.
So definitely finding a specialist is important, like yourself. Can you recommend any resources for people who are maybe in the Midwest, maybe in other countries, online resources to find those specialists?
Yes, there's 2 great resources. One is, there's 2. So one is Nancy's Nook. It's a Facebook group that will only allow you if you have endometriosis. And it's a great resource saying, let's say you live in Arkansas. I live in Little Rock, Arkansas. I'm looking for a good pelvic floor physical therapist, and I need to have surgery by a good excision surgeon. Can someone recommend somebody? So that's one, and Endo Warriors is another. Those are two really credible groups with great information, great admins who are very passionate about what they do, and they're just there to help facilitate learning and education, because the problem with endometriosis is that we as a group of gynecologists, we're not being taught properly in residency about endometriosis. So if the doctors, the generalists, are not being taught properly, they can't educate their patients properly. So the onus, unfortunately, is actually on the patients, because our American college has not updated our guidelines in way too many years. And so you really do have to learn all you can learn and educate yourself about endometriosis.
Definitely. Thank you for that. We'll link both of those resources in the group. And now going into the surgery itself, would you mind walking us a little bit into what the preparation is like? We know working with the pelvic floor PT, getting lifestyle diet set up. What does the actual, few days leading up look like, and then the actual surgery, and then we can go into recovery as well.
So typically what I try and do, like let's say that patient who I was talking about who has tight muscles and she has endometriosis, I try and have her start the PT, like I had said before, so she can start identifying, oh, wait a minute, this particular pain is getting better after I go to physical therapy. And that pain is getting better after physical therapy, but this other pain hasn't changed at all. So it's starting to help a woman sort of filter her different pains to recognize that they're coming from different places. Okay, so that's important going into surgery. And then we do a lot of talking. What if I find this? What do you want me to do? What if I find that? What do you want me to do intraoperatively? But I do minimally invasive surgery. I specialize in laparoscopy and robotic surgery. I love robotics for endometriosis just because the camera is a 3D high definition camera, and the instrumentation has wrists, just like my own natural wrists. And I find I can access the endometriosis much more efficiently from a robotic perspective. But they're little incisions. They're closed with medical crazy glue. You go home that day, typically. But the surgery could be on the shorter side. I never rush. I don't even wear a watch when I operate, but it could be shorter. It could be longer. There's no correlation between quantity of endometriosis and severity of disease. Meaning, someone could have a belly full of endometriosis and be practically almost asymptomatic, or that same person who has a belly full of endo can have debilitating pain. And the converse is true as well. Someone could have 2 spots of endo and have debilitating pain, or someone could have 2 spots of endo and have no pain. So we can't just go by someone's pain and know what their abdomen or pelvis will look like. My physical exam really helps me to have a good sense of what I'm going to find at the time of surgery. And I excise all the specimens. My whole goal is to try and make sure the benefits outweigh the risks, and to make sure I'm restoring normal anatomy. Because what happens, the endometriosis starts to stick to the bowel and the bladder, the ovaries, the fallopian tubes, and then it pulls on the pelvic floor muscles. It alters the nerves. So I'm trying to excise the endometriosis to restore normal anatomy.
Definitely. And what is I know that many women have to go through multiple surgeries throughout their lifetime. Is there any sort of trend in terms of spacing between surgery? Is it a feeling that a woman has? What does the follow-up look like?
So I think the most important is your first surgery done right by an excision surgeon. My reoperation rate's less than 5% on my patients. So it's but I get many patients who've already had 2, 4, 5, 8, 10 surgeries before they've gotten to me, because they're having tons of burning and laser ablation, which is A, not treating the endo, and B, causing worse problems because it's causing more scarring and more adhesions. So my advice is teens get endometriosis. We know that endometriosis has been found in fetal tissue. So a young girl who's 12 or 13 or 15 who's having debilitating pain going to the nurse's office, And if birth control is not covering her pain, we shouldn't say, oh, wait till you're 25 before you have your first surgery. No, because then a young girl who's 12 to wait until 25, that's 13 years of pain, right? 13 years of endometriosis growth. So we really have to individualize our treatment. And my best advice is, and this is part of the Cochrane Review, which looks at all databases to try and find the best medicine. And when they talk about ovarian cysts and endometriomas, meaning endometriosis cysts on the ovary, the first surgery done right is the best approach. And the same thing, if you're a teenager and you're having debilitating pain, birth control pills and nonsteroidal anti-inflammatories are not helping, you need to have a good excision surgery. That's what you need. I never tell patients, okay, I'll see you back in 2 years for your next surgery. Not at all. It's rare. And typically the patients who I do reoperate on are patients who we were able to excise a lot of their endo, but there are a few spots that if I did excise them, I may have compromised fertility. And if they're desirous of fertility, we're going to leave them in those spots, let them, God willing, achieve pregnancy. And then after they're done with childbearing, if they still, let's say, are symptomatic from those areas, then we do something more definitive. So that's a lot of my reoperation patients.
That's great to know that you're taking the patient's goals into consideration. And we did touch on a few myths, one being that you must have many surgeries. So can you talk a little bit more about other myths that are very common?
Yes. So big myth is that the way that we treat endometriosis is a hysterectomy and castration. Huge myth. That's what I learned in medical school, in residency. That's what was taught to me. And it's still being taught today. Now, if you take, what's the definition of endometriosis? Okay. The definition is when you have cells that are similar to the cells in the uterine lining or similar to the endometrium, but they're found external or outside the uterus. That's what endometriosis is. So why in the world would removing someone's uterus treat these cells that are found external to the uterus? So that's a huge myth. There's so many women across the country who have terrible endometriosis, but what's happening is their doctors are not going in and excising the endometriosis. They're leaving all the endometriosis, and then they're removing their uterus, meaning their reproductive organs. Then those women are actually in worse pain post-surgery than they were going into surgery. So that is a huge myth. And another myth, we don't remove a woman's ovaries or castrate them to treat endometriosis. So those two myths are just propagated through so much media, but they are not true.
Definitely. Thank you for addressing those. And we mentioned fertility. Can you talk a little bit about, for those out there with endometriosis who are trying to conceive or are trying to conceive again, can you talk a little bit about what you would tell those patients?
Sure. So first of all, I always tell patients, like, until you start trying, you don't know whether you have infertility or not. So just because you have endometriosis, it doesn't mean that you're not going to be able to have kids. But what I do tell my patients, if I'm diagnosing a woman at 22, let's say, I'm going to tell her that, yes, we do know that endometriosis can impact fertility. So don't wait until you're 35 to start trying. Or think about freezing your eggs if you're not in the right situation to have a child. The treatment of endometriosis is not pregnancy. Pregnancy doesn't make endo better. So I'm not telling someone to get pregnant whom it's not the right time, or they're not in a relationship, or they don't have the ability to take care of a baby. That's not what I'm saying at all. If you are in a relationship and you are thinking that, I'm thinking in 5 years, I want to have a kid, you may want to accelerate that process. Or think about freezing your eggs if you have the financial ability to do so. So I just let patients know that we know that endo can decrease fertility, and to sort of kind of maybe think about your plans a little differently, because we know if you take all women who don't have endo, fertility decreases at 35. So we don't want to have the natural decrease in fertility coupled with the endometriosis issues with fertility and decreasing ovarian reserve. So I think knowledge is power.
Definitely. Where are some credible resources where women who maybe are younger, maybe are older, who have endometriosis and who are looking for specialists who can help them plan their fertility journey, understanding endo? What are there any resources for people to look into practitioners?
Right. So I'm based in Los Angeles and in New York. I have reproductive endocrinologists who do free egg freezing seminars, usually once a month. So a woman can go and just learn about egg freezing. What does it entail? They usually have free evening lectures. But I think it's important not to just choose any reproductive endocrinologist. You really need to choose one who understands endometriosis, because a lot of reproductive endocrinologists will use a one-size-fits-all to help stimulate their patients. And ones who understand endometriosis and how endometriosis is inflammatory and how it behaves tend to have more success. So, I can guide people to those patients, at least in New York or in Los Angeles. And those would be great questions to ask on Endo Warriors and Nancy's Nook. Say, hey, I think we were talking about Little Rock, Arkansas before. I'm looking for a reproductive endocrinologist. Has anyone had luck with one who understands endometriosis? So you have to know that as a woman with endometriosis, you shouldn't feel isolated or alone, because endometriosis affects at least 10% of the population, probably 12. It's close to probably about 180 million women worldwide. So there's many women who you should ask questions to and query and maybe learn something from their path. They may be able to, fast track you to get the right answers based on where your geographical location is.
Definitely. And again, we'll put those in there. And also in our Facebook group, the Pelvic Health Support Group on Facebook, there are a lot of people out there. So just for everyone watching, engage and ask questions. And everyone introduce themselves on a thread. So you can probably go and look and see if someone's in your city as well. Let's talk about some other treatment options outside of surgery. I know that there are some pharmaceuticals that people take, some new things coming out. Tell us your experience with those.
Sure. So I wish there was a magic pill that a woman with endometriosis could take that's going to melt their endometriosis. It's not true, unfortunately. And for many women, endometriosis is genetic, meaning their mom has it, their aunt has it, their grandmother has it. They themselves have a 7-fold higher likelihood of having it. So if a mom has it, then the daughter has a 7-fold higher likelihood of having it. So you can't take an anti-inflammatory or a Motrin or an Aleve and it's gonna melt the endo. It may make the cramps a little bit better. So, you always want to start with anti-inflammatories, maybe try a birth control pill or 2. I wouldn't start trying 7 or 8 or 15 birth control pills, which is what a lot of the patients who come to my office have been put on by their gynecologist. Try 1 or 2 and try a continuous birth control pill after a few months when you feel that you're tolerating that particular birth control pill. If that's not working, go to the next step. Now, there are medicines, and I have to be honest, I'm not big fans of them because their side effect profile outweighs the benefit. And I'll be honest, I have 2 daughters. I wouldn't give my daughters any of the hormonal medicine. I'd give them birth control pills. I'd give them anti-inflammatory pills, but I wouldn't give my own kids or even my worst enemy a medicine that's going to cause hot flashes and weight gain and memory loss and osteopenia or weakened bones for someone to be on for 3 months, 6 months, or a year. And then you go off of those medicines and you still have those side effects. And now you're right back where you were before you even began those medicines. So I think the pharmaceutical industry has they're trying to find their niche, but I don't recommend medicines that have so many side effects to them. I honestly think one good surgery, one good excision, I'm not jumping into surgery for my patients, but one good surgery can be very beneficial.
Definitely. And I think that's one of the other things we've been learning just from all of our experts, including yourself, is that there isn't one magic bullet. and that we need a team of practitioners. We need a good pelvic PT. We need a good nutritionist. We need a good surgeon. We need community. And those are the things together that will get us down the line to less pain and just feeling better and healed. So let's talk about flare-ups. For your patients, when they're experiencing flare-ups in pelvic pain and really whatever, if it's endometriosis, if it's something else, what do you recommend to them to help with that?
So I think the hard part is I have a lot of women who come in and say, I'm having an endometriosis flare. I want another surgery. When in fact, it's not their endometriosis that's flaring. It's either tight muscles that they haven't been diagnosed with, or they have interstitial cystitis, which is known as endometriosis's evil twin, or they have an upregulated central nervous system or central sensitization. So I think it's important to really ask the patient to describe what are your symptoms, because most of the women who come into my office who feel like they're having a flare, it's actually these other coexisting conditions that were never identified, nor were they treated in the first place.
And that's again why it's so important to see a specialist like you who won't just open someone up if they're...
I love to operate, don't get me wrong. I love being in the operating room, but I need to do it for the right reason. And very often I don't need to take a woman back to the operating room all the time.
A few times you mentioned an upregulated nervous system. Would you mind breaking that down for us a little bit further?
Sure. So it's central sensitization is another name for it. So the way that I describe it to my patients is I usually take a step back so they can sort of understand how the central nervous system works. And I tell them to imagine a little kid who sees a burning, fiery red stove. And that little kid puts their hand on the hot stove, and the message goes up that kid's hand, up to their arm, up to their spinal cord, up to their brain. Their brain interprets that as pain and sends the message back down their hand and tells that little kid, hey, lift your hand up off the hot stove, right? That little kid is going to have a burn on the back of their hand. We call that an acute injury. All right. It maybe will last a few weeks. It's going to be very painful. Maybe the skin will slough off. Maybe after a month or so, the kid won't be in pain. Kid's certainly never going to touch that hot stove again. But what happens with endometriosis, and I think I think my patients really can understand when I describe it this way. I explain to them, your endometriosis is a hand on a hot stove. Okay. You're now 36. You've been telling me since you've had your first period at age 12, you've been either in the nurse's office or in your college dorm, or you've had to miss school or work. So that's a hand on a hot stove with messages going, ouch, 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 with no release, right? You can't let that hand up. And then what happens over time, typically from all that pain, a woman, let's say, assumes a fetal position, right? They're squeezing over, they're hunching. That starts to constrict the muscles. If they have constipation, they're sitting on the toilet trying to push out stool that doesn't want to come out. So that's another hand on a hot stove, essentially going, ouch, 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 that can't be lifted. What happens over time when you have the endometriosis hand on a hot stove, and let's say the tight muscle hand on a hot stove, and parenthetically, women with endometriosis go at least about 10, 11 years from the time they develop symptoms until when they're diagnosed. So that's a long time of these hands on a hot stove. What happens is now the central nervous system has so many of these inputs that it just starts firing on its own, essentially. That's central sensitization. So now we have a hand on a hot stove of the endo, hand on a hot stove of the tight muscles, and another hand on a hot stove of the central nervous system that's just so revved up. So we need to address that as well. And there's a lot of different approaches. You know, I know a lot of the physical medicine rehab doctors can address that much better than me, but there's a whole host of different medicines and lifestyle, all these different things to identify it and treat it. So that way, when you do have all of these hands on the hot stove, my job is to identify all the different reasons, slowly lift each hand off a hot stove, at the same time calm the central nervous system or the central sensitization, and then I operate on a patient. So we're going into surgery with the patient in the best possible shape as possible, as they can be, as opposed to taking them to the operating room with all these hands on a hot stove and upregulated central nervous system. And then they are in so much more pain post-surgery, requiring more narcotics, becoming more constipated as a result of the narcotics, worsening their tight muscles, worsening their overall pain, worsening their central sensitization. So I try and chip away at all of it preoperatively.
Definitely. Thank you so much for breaking that down. Okay, cool. Wow, I think we covered a lot. We definitely have some more time. Is there anything that I didn't ask you that you would like for me to ask?
I think what's really important is that it's not in your head. Endo is somewhat of an invisible disease, meaning you can have an MRI, you can have a CT, you can have an ultrasound, they're going to come back normal. Most gynecologists, like I said, their breadth of knowledge is so wide that their depth can't be so deep. God bless them, right? They do so much, but they're not going to pick up endometriosis. They're not going to pick up that most women with endometriosis have intestinal symptoms. Okay, so it's not in your head, and you really have to be your own advocate if you are in pain. That endometriosis could be, it's the source of your invisible pain. It's not invisible at all. It's invisible to the doctors and the radiologists, but it's not invisible at all. And it's very common, and you really need to be a proponent to get yourself to an endometriosis excision specialist and ask all those questions, because your first surgery is the most important surgery. And you can learn a lot from these different online support groups. And, don't give up. I'm actually writing a book right now on how to regain your life with endometriosis. And the prescription really is a mind-body approach. It's head-to-toe approach, incorporating all the different disciplines and dimensions that happen when one has endometriosis, and then what can you do to advocate for yourself with endometriosis. And you can get your life back. You really can. You just have to find the specialist, because the way medicine is these days, you're a master of nothing, a jack of nothing. What's that phrase? You need to be with someone who all they know is endometriosis.
Yes, I like to say an inch wide and a mile deep.
Yes, that's a good one.
Would you mind sharing some of your patient success stories?
I have patients who, like, one comes to mind, and this is very similar through a lot of my patients, who have had to quit their jobs. They've had to move home. They've had to have their parents support them. And then they just thought that they stopped dating if they weren't in a relationship, or their friends didn't want to hang out with them because they didn't understand what's wrong with them. And I've had patients then get better, become advocates, and get amazing jobs, move out of their parents' houses, and really start living their own lives. And I have that all the time. I have so many patients who come to me on disability who can't work, and they're in tears. All they want are kids, and their gynecologist is telling them they need a hysterectomy, right? One of the myths that is a cure for endometriosis. And we know that excision of endometriosis can improve fertility. And many of these women who, have already tried 2-3 courses of in vitro fertilization, they often can get pregnant spontaneously on their own. So whether it's regaining your life by getting your job back, or a new job, and getting back out there in the world, or achieving fertility that was unavailable or inaccessible before they came into my office. I have patients who want to be in their plays in their high school or in college, and they can't even follow or pursue their passion. And then they end up, after the surgery, being the lead in the play. So it could be something as being in a play, or success at work, or achieving fertility. But these are things that we see all the time. And I just to caution, it's not like they're going to come into my office and with a snap of my finger, their lives are going to get better. If you've had pain for 20 years, it's going to take some time for me to get you better. But if you follow all these different multidisciplinary approaches, you can get better. I think women need to be educated because their gynecologists are not educating them. But again, it's no fault of their own. It's the way the American College isn't educating the gynecologist. The American College of OBGYN, I mean.
Yeah, and that's why I found it so important, like, to interview you and to share it with this group and have this Pelvic Health Summit. Thank you so much for those stories. Like, those messages of hope are so important and really healing in themselves. So I know you are bi-coastal. Can you tell us where we can find you both physically and also online?
Sure. In LA, my website is lagyndr.com, like LAGYN doctor, so lagyndr.com. And my new office is actually opening up in Beverly Hills next week. Okay. And then I'm moving from another space I was in. And then in New York, I'm in Soho, and my website is nycrobotic.com, nycrobotic.com. Both my websites have tons of information on them. And, my consultations are very different than any other doctor's appointment you've probably been at. It's at least about an hour and a half, really listening, doing a really thorough exam, reviewing everything, and coming up with an individualized, comprehensive plan to help make each woman better and to achieve whatever it is that he or she wants to achieve. Yeah.
Thank you so much for taking the time to be here. This was so informative, and I just can't wait to have everyone watch it and learn from you. Thank you so much.
Thank you for inviting me to be part of this amazing summit.
Thank you so much for joining us. Now I'd like to hear from you. Please share with us one takeaway from the interview in the comments below. Give us a like and share this group with someone who you think will benefit. Thank you.